Well, greetings, everyone, and welcome to this week's EKG Case of the Week. Case of the Week for September 1st, 2014. Actually, this week I've got two cases that were just recently sent to me. And you know what? I have to tell you that these two cases exemplify what this EKG video series is all about. And they exemplify why electrocardiography interpretation is so important for all of us. And also why you need to be the expert. So let's get into this. The first case was sent by Andrew Bowman, who has sent a handful of very nice cases in the past. Andrew is an advanced care nurse practitioner working in an emergency department out in Lebanon, Indiana, and he's also got training and experience as a paramedic for more than 30 years. So he's been taking care of patients for a long time, and he sent this case. He was working in the emergency department when a 74-year-old woman came in with chest pain, shortness of breath, and diaphoresis. And this patient, by the way, has had an aortic valve replacement 2 months earlier, and at that time had a cath that showed clean coronaries. Well, now she's here with chest pain. She got some aspirin, some nitroglycerin, really no change in symptoms. He got an early 12-lead EKG, and here's the 12-lead EKG. This is, my interpretation is simply ugly. As they say, UGLY. This ain't got no alibi. This is... Yeah, even this EKG's mama would say this EKG's ugly, right? So what are you looking for on this 12 lead? Well, there's sinus rhythm, and what's really hopefully jumping out at everybody is the ST segment depressions that are diffuse. And when you see ST segment depressions diffusely, your next job is to go all the way around and boom, look in AVR, the lead that nobody ever pays respect to, but you've got to pay respect to this lead. There's ST segment elevation in lead AVR. It is probably greater than in V1. And when you see ST elevation in AVR, what are you thinking about? Well, you're thinking about left main coronary artery stenosis. You're thinking about triple vessel disease. You're thinking about proximal LAD. The worst of those three is left main coronary artery stenosis. And so he called up the cardiologist at the hospital where the original procedure, the aortic valve replacement, was done. This, by the way, is the baseline 12-lead EKG, so you can appreciate how much of a difference there is now between the baseline. Anyway, he called up the cardiologist, who said there's no way that this could be anything significant because she had a clean cath just 2 months ago. And so they had, well, what I would describe as a professional discussion for 20 minutes. And finally, Andrew was able to convince his cardiologist to take the patient. So the patient ended up being transferred over to the original hospital. And while they tried to manage the patient for a couple of hours, no surprise, if it's a left main lesion, medical management doesn't work. The patient had persistent pain. Then the troponin started bumping. So finally, they took the patient for a cath. And what do you think they found? Well, they found that the left main coronary artery was stenotic due to, apparently they said, from a suture from the valve surgery. Who cares? The bottom line is that the left main coronary artery was having some major problems. It was stenosed. From whatever the cause is, that EKG doesn't lie. Why would the EKG lie? The EKG has no incentive to lie to you. So trust that 12-lead EKG when it's combined with concerning symptoms. Who cares if the patient had a clean cath 2 months ago? When there's that degree of new ugliness on that 12-lead EKG... okay, all right, enough of that. When there's that degree of ugliness, you've got to take it seriously. And once again, kudos to Andrew for pushing and advocating for that patient and convincing that cardiologist who was resolute in saying that this patient's got a clean cath. There can't be anything wrong. This patient probably would have died had that left main artery not been opened up. So the patient ended up surviving, and that's a life saved because Andrew knew how to read that 12-lead EKG with some a little bit more than just basic knowledge. Next case, sent very recently by Dr. Randeep Tiwari. He works in San Ramon, California, recently finished residency at SUNY Upstate. So for those of you at Upstate, kudos to you for training this outstanding young physician. And anyway, Randeep was taking care of a 55-year-old guy who got brought in for exertional syncope. And by the way, the patient had some chest pain radiating to the left shoulder just before the syncope. So that's got to be concerning. chest pain associated with syncope, that's a big red flag. That's probably not just vasovagal, right? And then on top of that, this guy is not really in that age range where we typically think about vasovagal. We've talked a lot in past videos about what you'll look for on the 12-lead EKG for somebody that has syncope. Most of those cases, however, was just plain old syncope. This guy actually had chest pain associated with the syncope. So my first thought is this acute coronary syndrome? Is this PE? Is this dissection? Well, there's an interesting bit of information. When the patient woke up, he was completely asymptomatic, and he remained asymptomatic. Well, that's kind of interesting because I would expect that if a person's got a PE or ACS, probably dissection also, they're not going to stay asymptomatic. Anyway, there's the 12-lead EKG, and once again, your description could very simply be that this is another case of ugliness. Anyway, this is another ugly-looking EKG. You see that there's an incomplete right bundle branch block pattern in V1, and there's ST segment elevation in V1 and V2, and that phrase, that description 20 seconds ago should be sending alarm bells off in your head, light bulbs going off, and I don't know what else, whatever else should be going off in your head. That is Brugada syndrome, right? We've gone through Brugada syndrome before. If you're not familiar with Brugada, just go back over the videos over the past couple of weeks. Until proven otherwise, post-syncope patient who is now completely asymptomatic comes in with an incomplete or a complete right bundle, who cares which one it is, but there's ST elevation in V1 and V2, maybe even out to V3. This has to be Brugada until proven otherwise, or our new term, Martini syndrome, until proven otherwise, right? Well, they called cardiology on this, and cardiology said, well, there's ST elevation, he had some chest pain, let's take him to cath, because this is a STEMI. Well, hold on a second. STEMI, you can't diagnose STEMI in a person who's asymptomatic. Part of the definition of STEMI is, EKG changes and maybe some troponin and everything, but you've got to have some symptoms. You don't have to have chest pain, but you've got to have some symptoms. This guy's asymptomatic, so that just doesn't seem right. Anyway, they take the patient to cath, and guess what? Clean coronaries. No surprise there. They also got a CT of the chest, abdomen, pelvis in the hospital, which was all negative for venous thromboembolism, negative for aortic dissection. Those are reasonable things to think about also. Well, anyway, Randeep was still really bugged by this possibility of Brugada. He actually spoke with the cardiologist and the hospitalist, but they just kind of blew him off about it. My guess is that they really didn't know much about Brugada. And again, this is a nice time to remind everyone that Brugada syndrome is not common knowledge amongst everybody out there. It certainly is not common knowledge amongst internal medicine physicians. I don't know if it's part of their core curriculum. It is part of the core curriculum of cardiology, but that doesn't mean that they all know about it. And that's not meant to be an insult. It's simply a practical matter. The electrophysiologists know about this. They love to talk about this. They dream about it at night. They probably talk to their kids at the dinner table about this. But general cardiologists, invasive cardiologists, those are not the guys that deal with this. And frankly, those are probably not the people who need to know about this as much as the electrophysiologists. So they're probably not going to know about it quite as well. It's interesting, even at our own shop, the most experienced people obviously are electrophysiologists, and the cardiology fellows really know a lot about this because they're studying for their boards, but the general and invasive cardiologists, I'm not sure that they know as much about this as I would hope. So anyway, the general cardiologists, invasive cardiologists here, the hospitalists, they probably didn't know about it. They blew it off. And then when Randeep followed up on this patient a couple days later, the patient was discharged with no further workup. And he was really bugged by this. He said that he was losing sleep over this. So he actually tracked down the patient and got this patient in touch with an electrophysiologist, which is the cardiologist you've got to get him in touch with. And guess what? Patient's getting an AICD for Brugada syndrome. So that also, folks, that's a life saved, because he knew, Dr. Tiara knew about Brugada and didn't rely on the inpatient folks to have to know about it. And he got this patient hooked up with the right type of consult. So 2 lives saved because somebody knew more than just the basics of electrocardiography. So some quick take-home points here. We're not even going to spend take-home point slides talking about AVR or Brugada. We've talked about that many times before, and if you are not familiar with lead AVR, or you're not familiar with Brugada, just go to the website www.ekg.umem.org, scroll down the left side, and you'll see a search feature, and just type in AVR or Brugada or whatever you want into that search box, and you'll see a whole bunch of videos that talk about all of those. What I just want to focus these take-home points today, this week on, is this very simple point. You have to be the expert in electrocardiography. You cannot rely on your inpatient consultants to know more than you about electrocardiography. And one of my frustrations in emergency medicine is that all too often, emergency physicians and general practitioners also tend to assume that when their consultant says something, that is practically the word of God. It is not. If there's something that you know that your consultant is missing, don't just let go. In these two cases, the emergency providers, in one case an acute care nurse practitioner, and in the other case an emergency physician, didn't simply settle for what their consultants were saying. They advocated for their patients because of something that they knew about electrocardiography, and because of the combination of their knowledge plus advocacy, 2 lives were saved. Don't back down. I'm not saying that you need to argue with people. You can have your professional discussions with them. But if there's something that you're really worried about that your consultant isn't on board with, send them the literature. If that consultant's not buying it, get an article and say, well, what do you think of this article? If they say no, get another article. Say, what do you think of this article? AVR, perfect example. A lot of inpatient folks don't know about AVR. Give them another AVR article. And then let's say they stop answering their phone. Well, leave them a voicemail. Send emails to them. Let's say they stop answering the door every time you knock on their door to talk about AVR. Start slipping the articles under their door. Slip an article into their lab coat pocket when they hang it up somewhere. Give them the literature because there's tons of it, and eventually they will relent. And if they still don't, well, just get another consultant on board. Don't let your patients die. If there's something that you know and are worried about, talk to those consultants and don't give in until they understand what your concerns are. All right? So anyway, kudos to Andrew Bowman and Randeep Diara for saving 2 lives because of their knowledge and advocacy for their patients. And again, remember this key point. You need to be the expert in your hospital at electrocardiography. Don't rely on anyone else to know more than you. You've got to be the best. Well, I hope that case was helpful, those 2 cases, and I look forward to talking to all of you next week. Bye for now.